Hi everyone. Professor
Sorry,
here.
Prof. Said, and it's the housekeeping side. Yeah.
Okay. Hello? 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 Yes, please. Professor Monitor here.
You hear me?
Yes, I can hear you.
Yeah.
Hi
I'm just
everyone.
making. Oh,
I'm Professor Ahmed Said, who's the moderator of today's session.
how do I share my slides? Can you hear me?
Yes, Prof. Said, you may go.
Hi everyone. So it's Professor Muhammad Ahmed Said from Lahore, Pakistan. I'm professor at Institute of Rheumatic Diseases at Central Park Medical College, Lahore, and I'm also co-chair of the Arthritis Care Foundation and the current president of Pakistan Society for Rheumatology. I welcome you all on behalf of APLAR Academy, and it's really my great pleasure to have with us two speakers today, and we will be having this session. So, and I'm really indebted to all the conveners of SPA SEG as well as the Imaging SEG for putting this wonderful program together. So there are two talks. One which is like going to talk about by Professor Dennis McGonigal. So he's the professor and investigative rheumatology, University of Leeds, an honorary consultant rheumatologist, Leeds Teaching Hospital, NHS. He's going to be our speaker. We just need to check with our core team. Has he joined or is he going to speak? He will be speaking. His talk was scheduled as first talk, but he would be speaking after Professor Soosan Soroosh. So this is my pleasure now to introduce Professor Soosan Soroosh, who is Associate Professor of Internal Medicine, Division of Rheumatology, and she's working in Military University of Medical Sciences, School of Medicine, Iran. Professor Soosan Soroosh, before I hand over the podium to you, so there are just few housekeeping announcements. Those who would be are joining as participants in this Zoom session, you can see there is a Q&A function which is at the bottom of your screen. You will be typing your questions in that Q&A box and click then on the send button. If you would like to be asked a question from a certain speaker, just mention that speaker's name, and I will be conducting that Q&A session at the end, and hopefully, so we will have a great interaction. over to Professor Soosan Soroosh.
Thank you, Professor Saeed, for your introduction. Good morning to my dear colleagues from across the Asia and Pacific and beyond. It's an honor to discuss the three organs that make our AS patient miserable even when the spine is quiet. Those sneaky sidekick, skin, eye, and gut. Spondyloarthritis is an umbrella term that encompasses several inflammatory diseases. Sharing similar clinical and genetic characteristics, it is no longer just a disease of the spine. Skin, eye, and gut involvement are not extra. They are integral to the long-term outcome known as comorbidities. These comorbidities hard clinical outcome. Let's dive in. Statistics reveal that nearly 50% of patients will experience at least one extra-articular manifestation throughout their illness. Uveitis is the most prevalent, affecting more than a quarter of patients, followed by psoriasis at close to 9% and inflammatory bowel disease up to 7%. Perhaps most intriguing is subclinical gut inflammation, which can be found in a staggering 60 to 9% of patients, often asymptomatic initially, then lead to chronic form, higher as Crohn's disease and fewer as ulcerative colitis. The relationship between AS and extra-articular manifestation is dynamic. Typically, the onset of spondyloarthritis either precedes or coincides with the emergence of these manifestations. As disease progresses, the frequency of extra-articular manifestation, particularly uveitis and inflammatory bowel disease, increase. There is also a clear connection between gut inflammation and ongoing joint activity, suggesting a shared inflammatory pathway. Critically, the presence of one extra-articular manifestation elevates the risk of developing others, indicating shared genetic underpinning. This co-occurrence is not benign. It often correlated with more severe spondyloarthritis and predict a worse prognosis, including faster radiological progression and functional decline. Analysis, occurrence of acute anterior uveitis were not statistically significant between the male and female patients. In the female group, a tendency toward a higher occurrence of inflammatory bowel disease was statistically significant, especially for Crohn's disease. There were no significant differences in skin contingent between the two sexes. Uveitis prevalence significantly increased with disease duration, rising from 2% at 5 years to 39% at 20 years after ankylosing spondylitis diagnosis. The most combination of extra-articular manifestation in the long term was acute anterior uveitis and inflammatory bowel disease at 70%. Overall, 3 extra-articular manifestation was 10% during disease progression. Patients with comorbidity of acute anterior uveitis and psoriasis had higher disease activity score at baseline than patients without extra-articular manifestation. Data from cohorts in China, India, Australia shows higher acute anterior uveitis in HLA-B27 positive patients in East Asia populations, lower psoriasis, inflammatory bowel disease in some cohorts, especially due to underdiagnosis or genetic factors, and elevated subclinical gut inflammation up to 70%. Spondyloarthritis is like that invited guest at a party. It shows up in the spine, but brings friends to skin, eye, and gut. Today, I will politely ask them to explain themselves. Starting with the skin, where spondyloarthritis often wears its heart on its sleeve. It's important to recognize the various forms from plaque psoriasis to nail involvement, which is seen in about 50% of cases. Maybe underdiagnosed in Asia Pacific due to cultural reluctance to report genital or axillary symptoms. We must be aware of associated conditions like hidradenitis suppurativa or pyoderma gangrenosum 2. A key clinical point is that skin symptoms can precede joint symptoms by an average of 7 years, offering a potential window for early intervention. Skin symptoms in AS are usually less severe when compared with those seen in psoriatic arthritis. Nail involvement is a marker of more severe joint disease and may predict progression to psoriatic arthritis. Generalized pustular psoriasis is a medical emergency requiring hospitalization. It is rare in ankylosing spondylitis, but reported in severe cases. Most patients have mild disease, measured by PASI score below 10, though some reach moderate levels, scoring between 10 and 20. Cases with a score above 20 are uncommon, especially when psoriatic arthritis is not also present. Severe cases might be affected mental health, like depression, occurring in around 3% of patients in regions such as Singapore and Malaysia. Warm and damp weather could worsen symptoms. This gap might stem from genetic differences, such as reduced co-occurrence HLA-CW6 or lifestyle influence, like food habits or climate condition. Psoriasis in spondyloarthritis is like a bad tattoo. It itches, flakes, discomfort, cosmetic issues, and you didn't even choose it. But unlike tattoos, we have biologics to make it fade away. We'll focus on the eye, where spondyloarthritis can blur the lines. If you neglect red eye in ankylosing spondylitis, the patients may not be able to see your beautiful face again. These eyes demonstrate diffuse conjunctival injection, ciliary flash, commonly seen in HLA-B27-associated acute anterior uveitis. Men with ankylosing spondylitis exhibited higher incidence rate than women. Acute anterior uveitis in nearly half of axial spondyloarthropathy, often unilateral and recurrent. The history of acute anterior uveitis was associated with longer disease duration and older age. Vertically, the new onset of acute anterior uveitis was also related to longer disease duration and high disease activity index of AS at baseline and older age. Early eye involvement before diagnosis of AS occur in 26%. Recurrent acute anterior uveitis occur in up to 70% of patients, with nearly 50 to 60% of patients having more than 2 flares and 50 to 20% have more than 5 flares. Eye involvement, anterior uveitis up to 33%, posterior uveitis, retinitis, and choroiditis occur in less than 2%, panuveitis, rare, less than 1%, involving anterior, mediate, posterior segment is not typical in AS. Eye issue relate to higher BAS score, worse BAS-V score, enthesitis, and frequent attack. Mortality is indirect, but real and significant. Chronic eye disease can lead to depression, poor adherence, uncontrolled systemic inflammation, and accelerated atherosclerosis. About a third of HLA-B27 positive AS patients get self-limited transient uveitis that clear with topical steroid. Recurrent flares in moderate uveitis drive the long-term disease burden, ultimately impacting vision and well-being, although not mortality. Severe uveitis, which is chronic, bilateral, or complicated, is uncommon, affecting less than 5% of AS patients, and it poses a risk of vision-threatening complication, higher ocular disease activity, and indirect elevated mortality. These severe form of eye involvement, uveitis, with each flare increase the risk of complications, synesthesia, cataract, glaucoma, and macular edema. Vision-threatening complications occur in 29% of frequent relapsers. Now, let's look at the gut, the hidden battlefield when spondyloarthritis and inflammatory bowel disease interact. Widespread subclinical gut inflammation, near 68%, with chronic lesion, 45%, strongly predict Crohn's disease, and acute lesion in 23%. A subclinical gut involvement in axial spondyloarthritis is between 35 to 60%. This varies by region. This group with fecal calprotectin level above 150 microgram per gram, that marker ties to a 50% increased risk of progression with a standardized mortality ratio up to 1.7. Phenotypic spectrum of ulcerative colitis in patients with axial spondyloarthritis and inflammatory bowel disease overlap shows a clear gradient. This gradient covers disease severity, morbidity, and mortality tips. It ties directly to the anatomical extent of the condition. Limited disease, as proctitis, turns out to be the most common phenotype. If account for 30 to 50% of cases, this form adds almost nothing to overall mortality rate. Extensive disease, pancolitis, show up less often, about 20%. Even so, it comes with high complication rates and a 20 to 30% risk for colectomy. It has a major role in colorectal cancer mortality. In the end, this pushes up the standardized mortality ratio quite a bit for people with axial spondyloarthropathy and inflammatory bowel disease overlap. Left-sided colitis sits in the middle ground for risk level. It carries a real chance of spreading further up to the colon. Colectomy risk goes up moderately here. The same hold for colorectal cancer risk. The amount of colon involvement shapes long-term outcomes in a majority way. That means we need tailored surveillance and management approaches. The phenotypic distribution of Crohn's disease within the axial spondyloarthritis, ileocolonic Crohn's disease, is the most commonest subtype, 2 to 4% of all, overall associated with the worst prognosis and high rate of penetrating, fistulizing disease behavior. It is linked to highest systemic burden and mortality rate up to 2.6. Chronic Crohn's disease of the colon represents a sizable oncological lifelong risk up to 8%. It is also associated with significant rate of extramural complications, 20 to 23% of which are perianal diseases. Isolated ileal Crohn's disease shows up pretty often. It accounts for about 33% of all Crohn's disease cases. The thing is, it mostly gets driven by malabsorption and local issues like strictures. Most come with roughly a 50% chance of surgery. The absolute risk for cancer remains quite low in the end. Upper GI Crohn's disease is still rare overall. It plays smallest role in causing mortality in ankylosing spondylitis patients. The gut in spondyloarthritis is like a mystery novel full of twists and turns and unexpected inflammation. But unlike a bad book, we can't just put it down. We have to read the fine print with endoscopes. Ankylosing spondylitis has a standardized mortality ratio ranging from 1.6 to 1.9 by itself. Presence of other medical disorder accompanied by higher disease activity score up to 2.4 has a worse effect, especially in underdiagnosed condition as a stigma. It contributes to diminished functional capability, diminished working capability, partly due to psychosocial morbidities. Co-occurrence of these involvements lead to enhanced disease burden and increased rate of death in comparison to general population. AS patient with eye, skin, gut involvement has increased activity score, poor functional status, and increased disease activity in terms of radiologic changes. This highlights the importance of comprehensive care, including rheumatological, dermatological, ophthalmological, and gastroenterological expertise. Patient-focused care needs to take center stage with satisfaction, quality of life, and work productivity remaining the chief aim in management of axial spondyloarthritis. There continues to be an important knowledge gap regarding the optimal feature direction of microbiome studies in APAC enticity. Remember, managing spondyloarthritis comorbidities is like juggling. Keep an eye on the skin. Don't let the gut drop the ball and you'll see success. Thank you for your kind attention.
Thank you, Professor Soosan Soroosh, for your very informative lecture on axial spondyloarthritis and the comorbidities. Uh, uh, we are very delighted to have our speaker, Professor Dennis McGonigal, here with us today. Professor is working at Investigative Rheumatology Unit of University of Leeds. He's honorary consultant rheumatologist, Leeds Teaching Hospital NHS Trust. The floor is yours, Professor Dennis McGonigal.
Thank you, Mohammed. Can you hear me?
Yeah, exactly. We can hear you.
Can you see me?
Yes, we can see your slide.
Very good. I'm just moving to the start. Right. Yeah, thank you very much, Mohammed. Thank you, Suzanne, for that beautiful talk. Very, very clear. Excellent. I'm just closing the door because the dog started barking. Sorry about that. Right. So I'm going to talk about different mechanisms in psoriatic arthritis from the perspective of clinical stratification and from the perspective of therapy. And again, thanks for APLAR to asking me to speak. I have conflicts. Many of these companies you see on the slide fund research in our laboratory. And I'm going to be talking about, first of all, a big cause of heterogeneity in psoriatic arthritis is distinguishing between inflammatory and non-inflammatory mechanisms. And I'm going to be showing you data on that. And following on from the last talk, I'm going to be talking about how concomitant skin and eye and gut inflammation can make psoriatic arthritis more difficult to treat. So I'll talk about that. Okay, so first of all, I'm going to talk about psoriatic phenotypes, and I start in the difficult to treat RA space, where Nagy and colleagues said, you're difficult to treat in RA if you failed two biologics. And myself and Maya Butch from Manchester a few years ago published this article in Nature Reviews Rheumatology, where we said when people have difficult to treat rheumatoid in the skin colored circle, within that difficult to treat, there are two subgroups. One that have genuine persistent inflammation that needs to be confirmed by very very obvious synovitis that's multi-site, or raised CRP, or imaging positivity. And we split this into persistent inflammatory refractory rheumatoid, where there's active disease, and patients who have high DAS CRP scores, but they don't actually have objective inflammation. So we call this concept PIRA for persistent inflammatory refractory RA, and NIRA, non-inflammatory disease. So we tested this in rheumatoid in the real world in 1,600 patients. I'm doing this first, then I'll show you the psoriatic data. So we took 1,600 people with rheumatoid, many of whom had failed all available classes. Some of these people had failed 3 TNFs or even 3 JAKs. So we took 1,600 people, and some of these people in our clinic. So here's a patient with a high DAS CRP score and swelling of the second PIP on the right, and some swelling of the fourth MCP on the left. So when we scanned this patient, they had actually no power Doppler. So they had some osteophytes, as you can see here, and a little bit of fluid. So this patient is an example of high DAS CRP, but no objective inflammation. In comparison, this is somebody with a normal CRP, but a high DAS CRP, clinical joint swelling. Here we see it on the gray scale, and here's the power Doppler. So we started out with almost 1,600 patients, and of these, 15% were difficult to treat. I'll be showing you the psoriatic data in a second. And we called patients that failed all classes of drugs polyrefractory. Other people call them multi-drug resistance. Other people call it treatment refractory. So there's some confusion as to a unified nomenclature. But anyways, in this group, 2.5% had failed all classes based on clinical criteria. So we haven't applied the imaging yet. And then when we applied imaging, this is looking at those with high DAS CRP on the left, and then on the top right, it's those with high DAS CRP plus power Doppler. So that's the PIRA. And we found that the patients with rheumatoid that appeared to have difficult to treat disease, who had no inflammation, they had higher body mass indices. So again, the term clinical obesity in the medical notes was linked to the same. And you won't be surprised to find that patients with concomitant fibromyalgia were also more difficult, more in the more difficult to treat group. The reason I highlight fibromyalgia is it's a particular problem in psoriatic arthritis, but not rheumatoid, because enthesitis and fibromyalgia lead to tenderness in the same location. And in this work, if you don't have access to ultrasound, what we noted was people who had no objective inflammation on ultrasound, clinically they had a low swollen joint count of 2. But in people who did have a positive ultrasound, they tended to have 5 or more joints. So you can see that clinically it might be possible to pick this group out. And the CRP, the median CRP in the inflammatory group with the positive ultrasound is only 10. So it's very low. And the CRP in the inflammatory group was normal in 50% of cases. So just to highlight, the disease is not as bad as it used to be. And the group with objective synovitis on ultrasound, or PIRA, there was a lot more corticosteroid use. So just to say, so what does all of this mean histologically? So this is not done yet in psoriatic, but in rheumatoid, there's 3 groups when you biopsy the joint. There's myeloid and lymphomyeloid, and also what is called possiimmune, which is none other than fibrosis and probably osteoarthritis. So a group in Italy used our concept of NERA and PIRA this year, and they took biopsies of patients who lacked power Doppler. And so this here, if you look at this here, so NERA and PIRA are these 2 terms we coined, but I want you to go over to the right-hand side. And here we have the possiimmune fibrotic, PIF, and the yellow is lymphomyeloid and diffuse myeloid. So you can see that 50% of patients with a negative ultrasound, when you biopsy them, they have no objective inflammation. But the majority with a positive ultrasound have objective histological inflammation. Now, this group that the non-inflammatory group that have lymphoid and myeloid cells, the presence of cells alone does not mean they are pro-inflammatory. They could be pro-resolution or pro-repair, and that hasn't been answered in this paper. And the other thing to say, what's going on in rheumatoid? Again, this hasn't been done in psoriatic yet. This is a paper from last year from Dana Orange in the US. And what we're looking at here, everyone, is they've digested away the synovium to leave the blood vessels and the nerves. And what they find is that in chronic synovitis, these colors here, CD31 in pink is blood vessels, and the green is calcitonin gene-related peptide, vital in pain, and which is actually targeted to treat migraine. So that's the state of the art in rheumatoid. And what's more, when we look at X-ray progression in rheumatoid based on ultrasound, if patients have ultrasound power Doppler at one time point in this last couple of years, they have much more radiographic progression in those that have no objective ultrasound synovitis, where the lines are generally flat. So to summarize, I've just set the scene by telling you about difficult to treat and inflammatory and non-inflammatory mechanisms in rheumatoid arthritis. And that led myself and Alan Zabotti, Sybil Aidan, Paula David, and Andrea DiMatteo to come up with this concept in psoriatic arthritis of patients that have high disease activity where there is objective inflammation. So we call that persistent inflammatory psoriatic arthritis. And then non-inflammatory PSA or NIPSA. But the problem with psoriatic, as you can see, is it targets much more than just the synovium. There's the axial skeleton, periostitis, peritendinitis, and of course, most importantly, enthesitis, which we believe is the primary reason. Now, if you ask a patient with psoriatic arthritis, why are you complaining and why is your therapy not working? Top of the list, look, is pain and fatigue is second, and then stiffness is third. So you see that these things, including pain and fatigue, can be very subjective. And it's very important to realize that there's three facets to pain. It may be nociception in the joint or enthesis. It could be a neuropathic component in the nerve or dorsal root ganglion, and then it could be taking place in the spinal cord, the thalamus, the brainstem, or even cortical awareness. So just because there is no clinical inflammation does not mean, it does not exclude the possibility that this pain has been triggered by disease. So when you look at composite outcome measures for psoriatic arthritis, let's take MDA. And the blue things are non-inflammatory. So patient pain, patient global, and HAC, tenderness, and tender enthesial points are very subjective. Whereas swollen joint count and a raised PASI are much more objective. So you can see that in clinical trials, when you give an IL-23 or 17 blocker, 50% of patients get PASI 100s. But in clinical trials, MDA can be as low as 25%. And the point I'm highlighting is that unlike PASI, MDA is a mixture of subjective and objective features. And if you look at this, the PASI is very responsive. Many people get PASI 90s on biologics. Dactylitis is pretty responsive because you can see it. But enthesitis here, MDA, in many studies is around 30%. This leads people to erroneously say the drugs are better in the skin than in the joint, particularly with respect to IL-17 blockers. But I believe this is a mistake because we can't measure disease. So we called this PIPSA, inflammatory disease, as ADAPSA greater than 14 with imaging evidence of active disease, or if it's spine only, MRI activity and a NASDAQ score. And it has to be greater than 3 months. And to be inflammatory, it has to be confirmed on imaging, such as synovitis and ultrasound. And basically, I'm going to now talk about the key points in the management and adequate responders. So everybody agrees suppression of inflammation is very important, but the problem is we're not actually measuring it objectively. So I'm going to now focus on the three types of pain that are driving psoriatic. And I want to acknowledge that if we don't see inflammation, that does not mean it's psychosomatic. It means that the pain is likely driven from the dorsal root ganglion or the spinal cord. So here's an example of what we call a PIPSA phenotype. So the patient has a high DAPSA CRP, and then you scan the parts of the body where they're tender. So if they have power Doppler in the synovium, the peritendon, the enthesis, or say over the MCP head, when you see the power Doppler, you can categorize that as an inflammatory mechanism. So just like RA, this is now, we've tested this in the real world, not in 1,600 patients, but in 500 patients with Alan Zabotti in Italy. And this is Alan, who's first author. You can see all the co-authors here. So what we did is we took a lot of patients, 500, and we looked at those that failed 2 DMARDs. So 2 biological DMARDs. So RA, it was 15%, and psoriatic arthritis, 10% failed 2 DMARDs. So Then we looked at the ultrasound in these 50 patients, and basically 43% of these patients with a high DAPSA score had no objective inflammation around the skeleton. And the difference between these groups, the PIPSA group with imaging inflammation had a mean swollen joint count of 2, not that high. It's lower than the refractory RA where it was 5, right? Tenderness is the same. VAS is higher in the non-inflammatory group. The patient assessment is the same. And surprisingly, CRP was not higher in the inflammatory group. Couple of reasons. CRP does not go up in PSA, and then maybe metabolic factors are also important, but there was no difference in CRP. So this is what the data shows. In those with positive ultrasound who'd failed 2 DMARDs, there was more nail disease. The physician thought it was worse without ultrasound. Before ultrasound, the physician's score was much higher. If you had the patient global and subtract the physician global, you can see there's a huge difference. So the patients are overestimating the inflammatory component, probably because the pain has moved centrally. The swollen joint count, as I say, was higher in the inflammatory group. And very worryingly, the Spark enthesitis index was much higher in the non-inflammatory group. It was 5. So patients with high enthesitis scores have fibromyalgia. There was dactylitis only in the inflammatory group, and tenderness was, as you can see, much, much commoner in the non-inflammatory group. So this is showing this in graphical form.
I'm so sorry, Professor McGonigal. So may I ask you just to lower your camera because your face is not visible to everyone very clear. So I'm so sorry for that.
Oh, okay. I can't see myself. Can you see me now? Yeah? Is that okay?
Yes, Prof. You are visible on the screen now. Thank you.
Yeah, okay. Okay. Yeah, okay. Right. So this is I think the content in my slides, it's much better to see these beautiful pictures than see a less beautiful presenter. So this is in graphical form. So listen, rheumatologists, when you see your patients with psoriatic arthritis, if they have dactylitis or nail disease or any swelling, and you're feeling without ultrasound is pretty good. Whereas the non-inflammatory group, the physician is also very good, but the patients have lots of enthesial tenderness. So this is really important because there's a lot of recycling of drugs, and we're currently looking at this. So there are limitations to this. Of course, enthesitis may not be linked to imaging positivity, and there's lots of nerve endings around the enthesis. The power Doppler may not pick everything up. Patients may have an inflammatory flares between attacks. And of course, enthesitis is very difficult to assess. But just to give you context, this is a study from European registries in Scandinavia. And they looked at people that had failed multiple DMARDs, who had failed 4 DMARDs in psoriatic arthritis. The numbers needed to treat to get a response was 60 patients. So I think by the time you've failed 4 DMARDs, a lot of what has been treated is chronic pain and enthesitis, quote unquote. So I'm moving on now, and you heard the last brilliant talk from Soosan, and just to highlight that the psoriatic arthritis does come with overlapping features, particularly skin and gut, and also occasional uveitis and iritis, as you've seen. Just to highlight, when I see pan-uveitis and angst-Sponder psoriatic arthritis, it's usually in conjunction with severe anterior uveitis, and then the drainage of the aqueous humor into the vitreous carries inflammatory mediators back to the retina, so you get a pan-uveitis. That's what I think. So obviously, this is just highlighting when people treat psoriatic arthritis, they try and split it up into domains. But I think once you realize that the skin and joint are immunologically quite close, I think in general, but not always, if you clear someone's skin and they have lots of pain but no swelling, you have to seriously ask yourself, with these modern biologics such as TNF blockers, IL-17, IL-23 inhibitors, and JAK inhibitors. They treat both. So I think we'll get some convergence of these domains. So this is just to highlight there are some people who have a definite inflammatory phenotype, and sometimes the arthritis is worse, and sometimes the psoriasis is worse. And this is looking at a case series from the United States recently, where they had to use a JAK inhibitor and an IL-17 blocker, a JAK23 blocker, a 17 blocker, a JAK blocker, a 17 TYK2, 17 blocker TYK2, and a JAK and a guselkumab. I just want to highlight here that the safety profile of IL-23 17 blockers and TYK2 blockers is very good. So when you put those as an anchor drug, you can add in a JAK1 on top or a TNF potentially on top without getting an increase in toxicity. One of these patients then had to switch to bimekizumab. So this is just to highlight these rare phenotypes where usually the skin gets better on the 17 inhibitor or the 23 inhibitor, but the joint doesn't. And then physicians use a JAK. So of course, this is not licensed in most jurisdictions. This is very expensive, and we can't do this in the UK. This is just to highlight that there are rare psoriatic phenotypes that do not respond to treatment, who have polysynovitis and may have ankylosing spondylitis. And this is a paper where we treated these with combination ustekinumab and TNF blockers. This was back a decade ago when we started this. This combination was not well tolerated, and there was multiple infections, including sarcoidosis, which is probably an atypical mycobacterial infection due to blocking IL-12, which drives gamma interferon, and blocking TNF, which also drives granuloma formation. So gamma interferon and TNF drive granulomas. So this was a bad combination and lots of side effects, but I'm highlighting the point that with the more gentle efficacy, the more gentle toxicity profile of the 1723 pathway, you can do this. So this was just highlighting our work where we had these difficult psoriatics where we used this combination of IL-12, 23 and TNF dual inhibition that showed efficacy, but lots of infections. So I'm just going to say a few things now about JAK inhibitors and psoriatic arthritis. So why do JAK inhibitors work in psoriatic arthritis? Well, here's an example. IL-6 receptor SNPs come up in psoriatic arthritis and Angst-Spond. This is a mouse model of synovial endothelial complex inflammation. This is a concept we developed in 2007. So this mouse has inflammation at the tip of the Kager's fat pad. And this mouse's arthritis is TNF independent, but IL-6 dependent. So it's a seronegative disease. So when we treated this mouse with tofacitinib, here's the Kager's fat pad tip, all the amyloid cells are gone. And here's this strong, eosinophilic and staining due to all the myeloid cell infiltration. So it's just to highlight in an animal model that enthesitis, TNF refractory response to IL-6. So the point I'm making is that when we use JAK inhibitors, we not quite sure what we're doing because we're inhibiting up to 40 cytokines. So we lose that personalized approach you get with the other medicines. And this is a series that we did from Leeds with Dr. Mary Shelley, who's from Beirut. I was working with this. We had this case of patients that had a psoriatic phenotype, but very high CRPs. And they responded to IL-6 blockers, even though they had a SPA phenotype, and some of them are B27 positive. You can see IBD here and uveitis. So it's just to highlight this incredible immune heterogeneity in disease that's an issue. So I'm going to just highlight what we've been doing, looking at cytokines in the treatment of enthesitis. So this is a paper we just published this year in Arthritis and Rheumatology. Now, this is going to shock you. When you stimulate macrophages from the entheses with lipopolysaccharide, the IL-23 doesn't go up. But when you add upadacitinib, a JAK inhibitor, the pro-inflammatory cytokine goes through the roof. And then when you do bulk RNA sequencing, the transcript for the P19 subunit of IL-23 is remarkably high. So bacterial cell wall plus JAK inhibitor drives things up, which was a complete surprise. But what we found was what we found was when we treated the cells from the enthesis with the JAK inhibitor and focused on the T cells, it completely blocked IL-17A, here's upadacitinib, IL-17F, and IL-22, which is downstream of IL-23. And what's more, basically, we found that we could rescue this effect by adding recombinant IL-10. So when we added IL-10, we reduced this. So what's happening, everyone, is when you block interleukin-10 with a JAK inhibitor, you increase innate activation of myeloid cells. And you say, well, what's the relevance of that? Well, deucravacitinib signals through the IL-10 receptor, and IL-10 is very important in the gut. And this TYK2 inhibitor, which has a license in the US for psoriasis, it's getting a license for psoriatic arthritis. It failed in trials of IBD. So again, back to the first talk, these are the sort of things we need to be now putting in our head. We wouldn't use a 17 blocker for active IBD, as you saw in the last talk. But here also, it looks like TYK2 inhibitors, by having a negative impact in IL-10, could be detrimental in some SPA patients. And why is that, you ask? Well, humans that have mutations in IL-10 or the receptor are very prone to neonatal onset IBD. So here's our mechanism. You put your patient on a JAK inhibitor, and then there's a bacterial challenge. This drives up the cytokines like TNF and IL-23 in the myeloid cell. The macrophage makes IL-10, which is anti-inflammatory. That auto-regulates, but because the IL-10 signals through JAK1 and TYK2, you get paradoxical activation. But that makes no difference to the T cells, where the IL-23 and the T cell activation is completely flatlined. So this is Janus kinase. It upregulates innate immunity, but downregulates adaptive immunity. And another implication of this, many of our patients with psoriatic arthritis have metabolic syndrome and are obese, and we're quite reluctant to use JAK inhibitors. So the data I just showed you, Paula David from my group, last month in Annals, we took blood from active rheumatoid arthritis and we activated the macrophages. And this is looking at the rate of clot formation. The top is maximal clot, and then this is thrombolysis. So this is fibrinogen, the rate of fibrinogen conversion to fibrin, the maximum amount of fibrin, and then this represents the thrombolysis pathway. And when you treat macrophages with lipopolysaccharide and tofacitinib, you can see that things happen. Clots form quicker, and they're bigger and they're slower to break down. And this is 7 of our patients in this paper who had PE without DVT. And you see this ground glass appearance, which is compatible with local inflammation or immune-driven thrombosis in a patient with a PE here and a filling defect. So this is what we saw. This is the JAK inhibitor. This is tofacitinib here. The rate, the clots form a lot quicker, so the rate is faster, so it's lower. The maximal clot with tofacitinib is higher. And then when you look at the other JAK inhibitors, most of them are similar, apart from ritlecitinib, which is a JAK3 inhibitor, which is used to treat alopecia areata. So this paradoxical mechanism that's relevant to psoriatic arthritis, when we did transcriptomics of the macrophages from the blood, the thing that went up very high is factor 3 or tissue factor, which combines with factor 7 to activate factor, is it 9 or 10? Then it drives the extrinsic clotting cascade. And this happens with most JAKs apart from JAK3. So back to combination therapy. Going forward, there's a perception that combination therapy may be the way in difficult to treat or refractory psoriatic arthritis. We have no data, but here's a phase 2 study combining a guselkumab and a TNF blocker golimumab in patients with IBD. And in this study, the investigators did colonoscopy and they took biopsies pre and post treatment. So they have biological confirmation of disease activity. And after they used the combination, the two cytokine blockers, you had massive reduction in IL-23, massive reduction in inflammation, better epithelial repair, and fibroblasts became deactivated in the gut. And the combination was also clinically better than either monotherapy with IL-23 or IL-17. Now, that study, it's impossible to do a study like this in psoriatic arthritis because people just go on clinical joint counts. And as I've shown you, 40% have no objective inflammation. So this is why we're a bit behind in rheumatology because these guys are using biopsy at 2 time points, bulk RNA sequencing, and also single cell RNA sequencing. This is another thing I want to highlight when there is a psoriatic phenotype and IBD. It turns out that vedolizumab, the integrin blocker, also has an excellent safety profile because it only selectively blocks lymphocyte homing to the gut. So here are papers in psoriatic phenotypes where etanercept and the integrin blocker, golimumab integrin blocker, and infliximab in 3 cases is used. So there appears to be an ability to safely use combination therapy in our difficult psoriatic SPA patients because some of the agents we are using have such good safety profiles. We've also used apremilast in conjunction with biologics. You can see them here in Leeds to treat difficult psoriatic arthritis, and other people have replicated this. I'll look to the future. This is a study from Denmark where they used fecal microbiota transplantation, and basically patients who had fecal microbiota transplantation for psoriatic arthritis actually got worse. They got worse, not better. So I've been talking about psoriatic arthritis and how we stratify these difficult to treat disease. This is a paper we've done from GRAPPA, Fabian Proft, German rheumatologist, led on this. So we use difficult to treat in Leeds, but this paper talks about complex to management. So complex to manage means comorbidities have to be factored in. And then they call treatment refractory as failure of 3 DMARDs. Now there's more than 3 classes. So everyone who fails more than 1 biological DMARD is called complex to management. And then treatment refractory must have, they need objective signs of inflammation. So just highlighting this if you want to read it, it's just appeared online. And also Euler have just published definitions, and they don't call psoriatic arthritis difficult to treat. They call it difficult to manage, which is slightly confusing because they've changed the words from rheumatoid arthritis, which is difficult to treat. And this is difficult to manage and treatment refractory disease. So you can read this paper and it's easier to see here. So basically, difficult to manage patients have failed 2 DMARDs, so they're really difficult to treat. And then if they have objective evidence of inflammation, that's what we call the PIPSA phenotype, persistent inflammatory PSA with imaging positivity. Then this group are then called treatment refractory. But if you've only failed 2 DMARDs, say a TNF and a 17 blocker, well, you've still got PD4, 2 JAKs, and 2 IL-23 inhibitors, and even ustekinumab, which isn't so effective. But I wouldn't call it treatment refractory. So in conclusion, there's 2 things I want you to take away. First of all, difficult to treat and the challenges of PSA. First of all, we as physicians could be our own greatest enemies by cycling people through drugs on the erroneous belief they're difficult to treat, when actually many have no objective evidence of inflammation. Then the second thing I wanted to highlight is there is immunological heterogeneity in psoriatic arthritis, and there definitely is difficult to treat patients, and we're not quite sure how to optimally treat these. JAK inhibitors may have lessened this group, and then I highlighted that this difficult to treat group, tying in with the last talk, because they overlap with IBD and psoriasis, sometimes combination therapies are useful. And this seems to be pretty well proven in the gut, although phase 3 data is needed. It's very anecdotal in psoriatic arthritis. Trials have been done of combination therapy in psoriatic arthritis, but they're not in the public domain yet. But I caution because the psoriatic studies did not have objective inflammation. And I highlighted that JAK inhibitors do cause us concerns in psoriatic arthritis because of the oral surveillance study of increased cardiovascular disease in RA, and of course psoriatic patients having high BMIs, metabolic syndrome, non-alcoholic fatty liver, hypertension, hypercholesterolemia. You get the idea. We have a slight concern about JAK inhibitors, and then I've shown you our data about how JAK inhibition is paradoxically, some of it's not working in the gut. Tofacitinib doesn't have a license for Crohn's. It's not just deucravacitinib. And then I highlighted to you the novel mechanism, how JAK inhibitors cause thrombosis. So here are all the people that were part of the work I've just shown. And I'm very grateful for you listening to me on a Saturday afternoon, early evening. Thank you very much.
Professor Dennis McGonigal, that was a wonderful talk. I learned a lot from your experience of translational medicine to your lab, which you are doing incredible work. And I can see that there must be many questions to you, which we will be taking towards the end of the session. Now we would be moving to our next part of the session, which is actually going to be a recorded talk by one of ours discussing a few cases with us. She's Dr. Estella Gio, and she is working in Christchurch, New Zealand. So can we have her presentation?
Good evening, everyone. I'm Estella Yeo. I'm one of the rheumatologists from Christchurch, New Zealand. I would like to thank APLAR for inviting me to do a case presentation focusing on a case with multiple comorbidities. I've got a couple of apologies. Firstly, that I'm unable to attend this in person, hence the pre-recorded case discussion. And secondly, I'm just unwell with a cold at the moment, so I do sound a little more nasally. My apologies for that. So moving on to this case, so Mrs. LW, she's a 62-year-old female. So she first presented to a rheumatologist back in March 2017 when she developed painful left hand after a fall. Subsequently, within the next few months, she developed painful swollen toes consistent with dactylitis. And probably in early 2017, late 2016, she noticed that she has developed scalp psoriasis as well. So then she saw her GP and then was promptly referred to a rheumatologist. Her background history includes a past medical history of hypertension, which is reasonably well controlled, hepatic steatosis, which was thought to be non-alcoholic fatty liver disease, although she did have a past history of significant alcohol intake. She had cholelithiasis, colonic polyps, and chronic back pain, which has been investigated in the past that was found to be non-inflammatory in nature. So when she first saw the rheumatologist, her medications, she was just taking ibuprofen, 200 milligrams as required, on amitriptyline for the back pain, amlodipine for her blood pressure, also on quinapril hydrochlorothiazide for her blood pressure. And she was started on 10 milligrams in the morning by her GP already. So the initial examination showed that she does have active synovitis affecting her MCPHs bilaterally. There was evidence of tenosynovitis and dactylitis of both her hands and her feet as well, so fingers and toes. She had restricted left shoulder movement. There was a little bit of swelling in her right knee. There was definite evidence of scalp psoriasis, but they didn't actually mention nail changes. Otherwise, cardiorespiratory examinations were unremarkable. She had a non-tender abdomen, although liver age was just palpable, 1 to 2 centimeters below her ribs. Her initial investigation includes a normal full blood count and slightly raised CRP of 12. Her GGT was elevated, that would be consistent with her hepatosteatosis, but had a normal AST and ALT. Her rheumatoid factor and anti-CCP were negative, as one would have expected, and there was no erosive changes that were seen on the x-rays of hands and feet. So the thought was that, quite appropriately, she does have psoriatic arthritis. So the rheumatologist started her on methotrexate, went up to 20 milligrams. She only had partial benefit. She developed a little bit of loose bowel motion from the methotrexate, and essentially she wasn't able to wean off the prednisone. She was still probably about 10 milligrams of prednisone. And so in 2018, she was switched to leflunomide, which she tolerated, okay? And she remained on prednisone 5 milligrams daily in addition to the leflunomide as well. Now, 2019 was when things went haywire for her, basically. So she presented to hospital with fever, unwell, acute on chronic back pain. And eventually she was actually diagnosed with group B streptococcus septicemia from a T67 abscess. The abscess was too small to be drained, so she had 6 weeks of IV penicillin and then switched to orals after that. Her leflunomide was ceased and she had leflunomide washout, but she remained on prednisone 5 milligrams daily for her arthritis. During the hospital admission, she was also found to have a Child-Pugh A liver cirrhosis, and so initially thought, well, she's had a history of hepatic steatosis, but it has actually developed to a liver cirrhosis now. And again, they thought secondary to non-alcoholic fatty liver disease and past heavy alcohol intake. So she was probably drinking up to 2 bottles per week, although she did completely stop it in March 2019 before this hospital admission anyway. So she eventually did recover from this abscess, although it was a slow recovery. Then unfortunately in October, she had a fall and then had sustained a left ankle fracture. And she had to go to theatre for surgical intervention. So she had ORIF done. And sadly, it was again complicated by a wound infection and septic arthritis. And this time it grew Corynum bactrum. So she had a couple of washout, debridement, and eventually the metal wear was removed. And she was on IV vancomycin for 6 weeks. And at that stage, she was only on the prednisone, no longer on the leflunomide. And the thought is that the immunosuppression plus having liver cirrhosis does predispose her to infections. So understandably, she took a very long time to recover from 2 major infections in a single year. So in 2020, she saw the rheumatologist again, who then started her on sulfasalazine. One is that there is hopefully lower risk of infection, and 2 is that less likely to cause any liver issue with her liver cirrhosis. And she just continued on prednisone 5 milligrams daily. And actually, surprisingly, her arthritis was pretty well controlled for a good 5 years. So she didn't have any major issue with her joints at all. But throughout these few years, her main issue has actually arisen from her liver cirrhosis. So she has had multiple hospital admissions with hepatic encephalopathy. She also has significant ascites, and in the last 2 years had multiple admissions with peripheral edema, so shortness of breath and swelling. She had a few hospital admissions with esophageal varices when bleed, and they had to be banded. At some point in 2023, she was considered for a liver transplant, but overall felt that her condition wasn't serious enough to require transplant. And at that point, she was quite frail as well, so they weren't too sure whether she would be a good candidate. She did have a transdragular intrahepatic portosystemic shunt, which actually did help quite significantly with her ascites and her hepatic encephalopathy, and also did help with her varices as well. But she had persisting issue with the peripheral edema, so in about 2024, 2025 or so. And so there was a question of whether the low-dose prednisone is actually contributing to the fluid retention, and it most certainly can, because we know that prednisone does cause fluid retention. However, she is on quite a low dose only. And the second question that was raised is that would she actually be a candidate for anti-TNF, and also what is the safety of using anti-TNF in patients with liver cirrhosis. That up, and there was a couple of papers that I found, which I'll just screenshot and show everyone here. So this was an article that was published in Seminars in Arthritis and Rheumatism in August 2020, and it looked at the safety of TNF inhibitors in rheumatic disease in the case of non-alcoholic fatty liver disease and liver cirrhosis, which is exactly what my patients sort of the predicament she's in. So the key point was that in a case of non-alcoholic fatty liver disease, the use of anti-TNF is safe. In fact, maybe have a beneficial effect on the hepatic tissue. However, in the case of cirrhosis, it should be prescribed with caution and also get specialist advice mandatory before starting the treatment. And that's predominantly because of the infection risk. Then we found an article as well looking at the safety of anti-TNF agents in patients with compensated liver cirrhosis. And this article was published in a gastroenterology journal in October 2021. And again, they concluded that the use of anti-TNF agents in patients with compensated liver cirrhosis does not influence the risk of decompensation, serious infection, transplant-free survival, or even malignancy. Now, in New Zealand, it can be quite difficult to get onto anti-TNF for psoriatic arthritis, although it's such a wonderful medication. So I've attached over here, these are the criteria that our patients need to meet in order to get funded anti-TNF. So they need to have psoriatic arthritis for 6 months or longer. They would have had to try at least 3 months of methotrexate unless there is a contraindication. And they would have had to try either sulfasalazine or leflunomide in addition to the methotrexate, again, unless there's a contraindication. They need to have a certain number of active joint disease, so either 15 swollen joints in total, or at least 4 big joints, say the wrists, hips, shoulders, etc. And one of the hardest things to actually get funding for anti-TNF for patients in New Zealand with psoriatic arthritis is that they need either elevated CRP or ESR. So CRP greater than 15 or ESR greater than 25. And as we know that patients with psoriatic arthritis, it's not uncommon for them to have completely normal inflammatory markers as well. So in order to bypass that, patients then have to be put on prednisone 5 milligrams or more for at least 3 months in order to disregard that ESR and CRP. And we've had a lot of battle with the pharmac, which is the pharmaceutical sort of body in New Zealand, to see if that can be removed, like the criteria for the CRP and ESR, and we haven't had any lucks. So for my patient, I guess the thing is that she actually has pretty well controlled arthritis on the sulfasalazine and prednisone. So we just have to, we had to be a bit more innovative to get her funded for this anti-TNF. Anyway, the progress was that we spoke to gastro. They agreed that it would be safe to use anti-TNF. They've done their research as well. So she was actually started on Amgevita, which is a adalimumab biosimilar that's available in New Zealand. And then she continued her sulfasalazine. She did have a suboptimal short-acting test, which because she has been on prednisone for such a long time, and because her arthritis was actually pretty well controlled, I switched her from prednisone to hydrocortisone. And when I saw her a couple of months ago, I'm pleased to hear that she feels actually extremely well. Her arthritis is still well controlled despite not being on prednisone. Her fluid status and her weight are all fairly stable. It's not going to make a drastic difference by stopping the prednisone, I think, but at least things are not getting worse. So this is my tricky case of a patient with psoriatic arthritis with multiple comorbidity. Thank you.
Thank you, Dr. Estella. So we really missed your presence and we wish you a quick recovery. So now we are towards the end of our session. I would like to take up the Q&A. We have a few questions from our participants. The first question is for Dr. Soosan Soroosh. Did you recommend doing calprotectin for all patients of axial spondyloarthritis to exclude subclinical gut involvement?
Actually, since it shows only 50% of patients, if you adjust the false positive and false negative of these tests, it may be a chance to show what's going on and what's happened in future of the patients, maybe.
Maybe. So I'm also asking the same question to Professor McGonigal. Would that help in choosing a biologic for our patients versus a JAK inhibitor if somebody has a calprotectin and high? And would you then, in that case, consider not consider IL-23 or tofacitinib in that case? Sorry, your mic, I think you have to unmute yourself.
Yeah, thank you. Yeah, thank you for the question. Yeah, we only check fecal calprotectin if the patient has some symptoms or, possible diarrhea or change in bowel. But irritable bowel, IBS, is very common, so we do end up doing it. And I think if it's less than whatever 50 micrograms per whatever gram, we don't do anything more. So we don't usually use the test unless the patient is symptomatic. Then if they are symptomatic and it's negative, we would tend to treat. But I think if once there is tummy symptoms and any suggestion of a raised fecal calprotectin, we usually have enough treatment options that we may be able to avoid sending the patient for a colonoscopy or MR enterography. Yeah.
Thank you. Thank you both. Then we have an attendee who has asked about the issue of classification. So somebody who has psoriasis and have arthritis with axial involvement, and at the same time we have a patient who have inflammatory bowel disease, and still we can classify as the New York classification criteria as AS or as ACES criteria as EXPA. So how would you address that? Because at times these patients can be axial PSA or enteropathic. So how do you go about it? Soosan, and then to Professor McConaughey.
As I said at the first part of my speech, it was not anymore external. It is integral part of ankylosing spondylitis. As I said, it is part of this, and you must calculate the disease activity score, which is higher than usual, and decided to treatment according to patient center and the vital organ involvement.
Okay, so how do you address Professor McConaughey? So such for purpose of classification, because as such there is no therapeutic dilemma much, but this is like classifying for research purposes or giving a code, ICD
Yes.
coding to the patient.
Okay, well, the way I'd look at it is if they're HLA-B27 positive and they have sacroiliitis or MRI osteitis, I would very view it much as a B27 non-radiographic axial SPA or if they have X-ray changes, AS. In the case of axial psoriatic arthritis, we published a paper on this 2 years ago in December 23 in Nature Reviews Rheumatology, where we highlight that the AS phenotype involves the bone osteitis, so you have sacroiliitis, etc., where the axial PSA phenotype is much more likely to have a negative MRI for osteitis, and on X-ray they have chunky syndesmophytes involving the spine and neck, and basically that phenotype is overlaps with IBD, but it's linked to the inflammation taking place in the ligamentous soft tissue rather than the bone side. So that could be useful for labeling the patient as axial psoriatic arthritis, but more research is needed in this space.
Thank you, Professor. Yeah. Professor Soosan, our colleague Kitty Pong has asked about the prevalence of acute anterior uveitis. Is it higher in Crohn's versus ulcerative colitis, or is it like same?
I have an exact prevalence of this, but as I mentioned before, the Crohn's disease is more prevalent in spondyloarthritis than ulcerative colitis. By this chance, this combination is more higher than by ulcerative colitis.
Okay. Thank you. This is a question which is actually I keep on wondering, one from CRP or high sensitive CRP, which one is best to do in patients when we are measuring the disease activity in PSA or in SPA on the whole? Professor Dennis McConaughey, I would like you to address this.
So in our setting, we used to have a CRP cutoff of 10 milligrams per liter. Now it's 5. So I know there's lots of argumentation about using even higher cutoff. I'm not sure. We're stuck on a cutoff of 5 until there's clear evidence that taking higher values is better. Conditions like ulcerative colitis, where the inflammation goes into the lumen of the intestine, so you don't see it so much systemically, the CRP is normal. And conditions like ankylosing spondylitis, where a lot of the inflammation is at enthesis, which are very well innervated, and you don't get synovial swelling with overspill into the blood like rheumatoid. You can have a lot of pain from inflammation without a systemic response, I believe, in both colitis and ankylosing spondylitis. So I think it's an intrinsic part of the disease process that the CRP is low, rather than an issue with measurement. Because the lower you go, you're going to pick up other things like, atherosclerotic disease, secondary osteoarthritis, other tissue, sinus problems, etc. So I don't think dialing down the CRP on its own is going to help a lot.
Thank you. One question which actually from Pakistani paper on the use of guselkumab and golimumab in combination. So how should we be addressing such combination when thinking about such combinations and mitigating the risk of infection in these patients? So what would be your take?
Yeah, well, yeah, my point wasn't to promote the use of dual biologics in difficult psoriatic arthritis, psoriasis, IBD overlaps. It was just to highlight that historically, around the turn of the millennium, rheumatologists used combination etanercept and anakinra in rheumatoid. There was no extra efficacy, and there were severe problems with infection and neutropenia. So that's the historical legacy we rheumatologists have. But now here we are 25 years later with this class of drugs, the 23 blockers and even 17 blockers apart from Candida, and TYK2 blockers, and even integrin blockers in the gut, where they have a remarkably low rate of infection. So that means you have that means when you use a drug like a TNF inhibitor or a JAK inhibitor, it seems that you might be able to couple those to these efficacious partner drugs that have very good safety. And that's what the phase 2 data in IBD has shown, is that this appears to be safe, at least in the short term, and also potentially efficacious. So we don't know yet about psoriatic arthritis. A trial has been done, but it hasn't been reported. But I think the safety will be good. But the question is around efficacy, though. So I think this is going to be an important area in the next decade. We're good at treating psoriatic arthritis. We're good at treating psoriasis. We're good at treating IBD, uveitis. We're generally good. It's when these four things meet, it looks like combination therapy will have a place based on the preliminary data. But in that study called Vega in Lancet Gastroenterology and Hepatology, in that study, there was no increased risk of infection in the combination guselkumab and golimumab arm.
Thank you. So there is another questions from Dr. Geeta Harifi, again directed to Professor McGonigal. Why do you think that selective JAK3 inhibition didn't produce the same prothrombotic effects as with other JAKs?
Yeah, so this is in vitro work in the lab. What happens is IL-10 receptor is a brake or a regulator of inflammation, and IL-10 signals through JAK1 and TYK2. So it doesn't go through JAK2 or JAK3. The ritlecitinib, the JAK3 inhibitor, is highly specific for JAK3. The available JAK2 inhibitor, ruxolitinib, which is used in myeloproliferative diseases like polycythemia rubra vera and essential thrombocytosis, because they have gain of function mutations in JAK2. That's not completely specific for JAK2. It has some JAK1 effects. So that may partially block JAK1. So the simple answer to the question is the IL-10, which is the main cytokine involved in this immunothrombosis, uses JAK1 or TYK2. And of course, these are the JAK types used in rheumatology. Rheumatologists don't use JAK2 inhibition so much. There are cases of macrophage activation syndrome or HLH in hematology treated with ruxolitinib. So it has been used. And then the ritlecitinib is only used to treat alopecia, autoimmune alopecia areata. So yeah, the bottom line is it's possible that a bespoke JAK3 trial in high-risk rheumatology patients may give the same efficacy, although that needs testing, but would get rid of the risk of venous VTE. Yeah.
Thank you, everyone. And in the interest of time, so there are a couple of questions, but we have to say goodbye to everyone. And we are really grateful to our both speakers, Professor Soosan and Professor McGonigal. And thank you, all participants, for joining and making it this event successful. In the end, I would really like all of you to scan this QR code or follow the link after leaving the webinar, and we would love to hear from you. And thank you again for all joining and having me to contribute to this symposium. And just also look at these upcoming events and mark your calendar. So there are very exciting events coming up from APLAR Academy. Thank you all for being here. Have a
Thank you,
wonderful day.
Mohammed. Thank you very much.
Thank you.